Thank you, Dr. Mona. Now, ladies and gentlemen, we welcome our guest of honor. Dr. David Livermore is a doyen amongst microbiologists. We know that several generations of clinicians and microbiologists have grown up with his teachings and learnings. Dr. David Livermore has shaped our knowledge about bacteriology and antimicrobial resistance through his brilliant, ceaseless, cutting-edge research. Sir, you have a huge number of fans all over the world. You have one fan waiting for you right around the corner, and that is our very distinguished guest, Dr. N.P. Singh, who is head Department of Clinical Microbiology, University College of Medical Sciences. He himself is a crusader of antimicrobial stewardship in a big way. Dr. N.P. Singh, will you please introduce yourself and then do the honors of welcoming our esteemed and illustrious guest of honor?
Yeah, good evening from India. I'm Dr. N.P. Singh. I'm Director, Professor, and Head of the Department of Microbiology at UCMS and GTB Hospital. And I'm grateful at the outside. I'm grateful to the organizers of Virtual Annual Symposium 2022 on Antimicrobial Stewardship and Patient Safety for giving me this wonderful opportunity to introduce today's guest of honor, Professor David Livermore, a doyen of medical microbiology, a sunshine of all microbiologists and clinicians at the same time. And I'm following Sir since 80s when since 80s when our first paper was also published in Journal of Antimicrobial Chemotherapy, and I know that Sir has edited that journal. So Professor David Livermore has enriched the world with a staggering 500 profoundly thought-provoking publications which cover the entire gamut of bacterial resistance. He has pioneered research on antimicrobial resistance in a veritable plethora of microorganisms and has enriched the world with his meticulous, painstaking research. His work has influenced several generations of microbiologists and clinicians alike. Across 40 years, he has belonged and then led teams that have defined the evolving epidemiology and molecular nature of antimicrobial resistance. He regularly appears on Clarivate's most cited list, has edited for multiple journals like Journal of Antimicrobial Chemotherapy, International Journal of Antimicrobial Agents, Journal of Medical Microbiology, and has served on many UK government's advisory committees on antimicrobial resistance and healthcare infections. He consults widely for the medical industry on antibiotic development and rapid diagnostics. He is currently leading an important multi-pronged, multi-centric study called INHALE, which will have far-reaching consequences as it studies the utility of molecular diagnostic tools in leading to better patient outcomes, promoting antimicrobial stewardship and cost saving in hospital-associated pneumonia and ventilator-associated patients vis-a-vis the conventional lab practices. At this time, he has given an important guidance to all of us, and I will quote his guidance. That is, I quote, always look at raw data and ask, what is this telling me? And not how does it support conventional opinion? If the data show something unexpected, find a second way to test and hopefully confirm it. Once you are sure you are right, publish and stand by your findings, whatever conventional wisdom may upset. Alongside Dr. David Livermore has walked entire perimeter of United Kingdom and Wales and half of the Scotland. Sir, I once again welcome you. In this conference on antimicrobial stewardship and patient safety. Thank you.
Okay, thank you for the kind introduction. It's presently telling me I can't share my screen. Perhaps I'm being impatient.
Yes, no, I have to stop sharing. Just a moment, sir.
Okay, I am being impatient.
This is where this machine is stopping me. It stopped. Yes. Very,
Okay,
very welcome, sir. We are absolutely thrilled to have you with us as always and looking forward to your presentation.
and now you should be seeing my screen, yes?
Yes, sir.
Jolly good. Well, thank you indeed, Mayor. Thank you, Dr. Singh, both of you, for the very, very kind and generous introduction. I'm not sure grateful. Ladies and gentlemen, as those quotes have just said, I would urge you in any study, in any piece of scientific work, to always look at the data, always keep asking yourself questions about it, always try to be rigorous. We've just now lived through what, 2.5 really remarkable years of the pandemic, when, at least in my country, and I think in many of yours, we were promised initially that we would be led by the science. But I fear we were not led by the science. I fear that we were led very frequently by the propaganda. I don't seem to have heard, at least in the major scientific journals, nor in the major media, a debate on the cost benefit of lockdowns. Yes, they may have slowed circulation of the virus, but they cost an absolute fortune. The costs will have to be repaid over many years. That will impoverish people. It will harm public health. Where has the debate been about the value of vaccinating children who are of minimal risk from COVID and who, if they catch it, will be protected for longer than they would have been by the vaccine? About masks, where the WHO said that were of no value before the pandemic, where 2 trials done during the pandemic found no value, and where country after country has imposed mask mandates without any impact on rising trajectories of COVID. We desperately need good, hard, rigorous, objective science. And with that, let me turn to antibiotic resistance, where surely we have a problem. Here's the map of Europe. We're looking at carbapenem resistance in Klebsiella pneumoniae from bloodstream infections. Look at Italy there, 2% resistance in 2008 to 30% resistance actually by 2012, let alone 2015. And see the other countries turn the warmer colours as resistance rises. Slovakia, Romania, Greece. Real problems for many of these organisms are highly resistant to multiple antibiotics. But I would be very, very wary of extrapolating those sorts of observations for intensive care unit patients to statements like this, and we've heard a little echo of them this afternoon or evening. This was one from our chief medical officer in the UK, that drug resistance could take all healthcare back, take healthcare back to the 1800s, to destroy those gains in life expectancy. Well, let me answer the question posed today, and let me comment on that headline. It's not going to. This isn't 1800. Bacteria, medical bacteria hadn't been identified in 1800, so we can't certainly say what was going on except for classical infectious diseases. But this is the 1940s, if you look at the left-hand panel, and these are bacteremias in hospitals. And what you see immediately is that 90% of the bacteremias were caused by gram-positive pathogens, and half of them by strep pyogenes. Strep pyogenes has remained entirely susceptible to penicillin and multiple other antibiotics. Staph aureus, that's the deep royal blue colour, another big slice. Yes, it has been adept at developing resistance, but when I last counted, we had 13 antibiotics in 9 different classes, which were near universally active against Staph aureus, including MRSA. We're not going back to 1800. We may be hitting problems with treatment of a few classical infectious diseases, tuberculosis, gonorrhea, and some of our advances in terms of intensive care medicine, where we see multiple resistant gram negatives are at risk. But we're not going back to 1800. But we mustn't be blasé. We should do what we can, where we can, how we can, to reduce the rise in antibiotic resistance. And we have to be candid that there's a lot of bad antibiotic use which drives resistance for no really very useful medical purpose. This slide, and forgive the rather complicated axes on it, but the horizontal axis there is amount of beta-lactams used, and the vertical axis is a measure of the probability of resistance to beta-lactams in a pneumococcus, in Streptococcus pneumoniae, and the codes are different countries across Europe. So what you see is countries like the Netherlands, Denmark, Sweden, Finland, to a degree the UK, have relatively low usage, low rates of resistance. But if we go to the other end, Belgium and Portugal, Italy, high rates of usage, high rates of resistance. And the populations of Portugal, Belgium, and Italy are not noticeably healthier as a result of that rather heavy usage. We can also look across individual hospitals, and this is the UK. Total antibiotic usage per 1,000 occupied bed days is an OBD. So it's a measure of amount of use per occupied bed. And if you chop off the bottom 10% there and the top 10% over there, those are mostly unusual specialist hospitals, psychiatric places at this end, and major transplant centres at the other. What you see over the 80% in the middle is about a 2-fold variation in antibiotic usage. Why on earth are the places at this end using twice as much antibiotics as those at this end? Do they have better outcomes? Do they have worse outcomes? Are they being wasteful or not? These are things we must answer. Where is the optimum on that graph for a normal district general hospital? As I say, forget the very top, the very bottom. And let's also be candid, there's a lot we don't know. I've shown this graph many times, this picture many times over the years, and nobody's yet managed to give a clear answer. These are 3 models of empiric prescribing control within a unit. The first one's restricted. For a type of infection, say a complicated UTI, we standardly give antibiotic A. We give it to every single patient, and only once we've destroyed it do we switch to using antibiotic B. Is that the best thing to do? If you think about gonorrhea in the community, it's how we've destroyed successive antibiotics, one after the other. Sulfonamides, penicillins, tetracyclines, fluoroquinolones, to a degree cephalosporins. Is cycling better? 3 months where A is standard of care, 3 months where it's B, 3 months where it's C? Or do you just destroy all those antibiotics together? Or is it best to get a diverse, mixed usage of antibiotics? We desperately need good studies that resolve this. The people who've tried to do it have tried to do it in ICUs, which may well be the very hardest place of all to try. But let me now turn in my last few comments to community urinary tract infections, because needless to say, that's what SERV's concentrating on. It's what accounts for so much of community antibiotic usage. And we all, I hope, agree that somebody who's got a UTI does need an antibiotic for treatment. It's not like a community respiratory infection where lots of the people getting antibiotics had a viral infection and didn't need them at all. This is from a European survey recently published. And I put it up to make the point that our standard old antibiotics here, cephalosporins, amoxicillin clavulanic acid, if you prefer, ciprofloxacin, trimethoprim, all have resistance rates of 20% or more. Increases the hazard of failure. And remember that these UTIs are the commonest source of E. coli bacteremias. If you've got a UTI, you're actually very unlikely to get an E. coli bacteremia. But nonetheless, more bacteremias come from E. coli UTIs than any other source. So we can stop those that are going to give to a more serious infection. We do the patients a big favour. The antibiotics with lower resistance rates, May has mentioned them already, fosfomycin, nitrofurantoin, mucilina. They've kept their activity better. Their limitation is that they are no good if the infection has started to ascend. So here we have a conundrum. The antibiotics, which were good if the infection had started to ascend, are compromised by resistance. The antibiotics that are keeping their activity well, that aren't compromised, are not so good if the infection started to ascend. Here's what's gone on in the UK, and I apologise for this left-hand panel because it's a plot that's a little hard to get your head around. Trimethoprim as a proportion of trimethoprim plus nitrofurantoin. So the dotted lines are individual UK regions. The orange line is the mean for the whole country. So it comes down. What that means is trimethoprim's going down. What it doesn't show you directly but has to follow is nitrofurantoin is going up, precisely because we got concerned about the prevalence of trimethoprim resistance and switched to a drug, nitrofurantoin, to which there is much less resistance, but we know is less good if the infection started to ascend. What's happened to E. coli bacteremias? Well, they kept going up all the while. I've truncated the graph at 2019 because in 2020, needless to say, we had a lockdown. Numbers went down, but I fear that's because patients didn't present to hospital and some died at home in consequence, or some who were about to get a bacteremia at the end of their lives got a COVID instead. But it again shows you the complexity here, that we switch you into a drug that in terms of resistance is better, but which has its own limitations and which hasn't caused any immediate shift in what we want to change, those E. coli bacteremias. Ladies and gentlemen, I've talked quite enough, but hopefully I've made my message clear, which is always think, don't fall for hyperbole, recognise exaggeration. COVID has been a nasty pandemic, that's for sure, but it has not been one of the great plagues of history, and what we did may well have been disproportionate. And yes, we have serious antibiotic resistance problems. We have a few classic infectious diseases which are becoming hard to treat. We have a big problem in specialist hospital units, but we're not going back to the pre-antibiotic era. And turning to stewardship, and stewardship's actually critical to what Dash is trying to do. We know what bad stewardship looks like. It's profligate antibiotic use. We still don't quite know what optimum stewardship looks like. as we must test different things, we must keep an open mind. We must try to find out what is that best compromise on antibiotic usage, which preserves antibiotics for the future, which is encouraging antibiotic development, but which simultaneously gives the best treatment we can for our patients, to whom our first duty lies. Thank you.
Thank you so much, sir, for that excellent guidance, for reassuring us, and for telling me for the hyperbole that I did. And I did it exactly for this, so that we come back to where we really stand. Are we going back to the 18th that you put there? I would have thought that, I mean, I'm talking about LMICs here, really, where the health standards may not be optimum. And could we say the standard of living will keep our life expectancy to 50, or we will continue at 60, 70?
The future is unknown and unknowable. All we can try to do is work as best as possible on present evidence. But hyperbole is also useful because it creates debate. It's dangerous when it's used in the way it was with COVID. Very dangerous.
True, true, true. Absolutely. So we went overboard there. We should not go overboard with our fears for the future. We should be very careful and what should we say, judicious in our usage. And of course, as a whole world, not just healthcare practitioners, but the whole world needs to be on board on utilizing these very important resources. Sir, it was an amazingly wonderful presentation. Again, pearls of wisdom from you, which we will keep and preserve till next year when we meet you again and learn some more pearls and keep them to our heart. Thank you so much, sir.
My pleasure. I shall enjoy listening to the rest of the symposium.
Our honor, sir. Our honor.
Okay.